Thank you so much for attending this panel. It's called Putting Prevention First. And when we were talking about what we wanted to focus on for this panel, it was interesting how almost everyone had some interest in research in the obesity epidemic, and that just very clearly emerged as one of the most important things that we could talk about. And it seems like a very timely day to be talking about weight control, because I'm surrounded by pumpkin spice lattes and my house is full of Halloween candy. So I know weight is something that we're all going to be battling over the next few weeks. But in addition, there's also been a lot of news about obesity, really striking increases in the rate of obesity in the United States, with almost 40%, I think, of American adults being obese, almost 20% of kids. Those are really striking numbers. So we're going to talk a little bit today about what are some of the health consequences of obesity. And I thought we could just let our panel have everybody introduce themselves as well. So as you know, I'm Liz Szabo with Kaiser Health News. And can everyone just kind of briefly introduce yourselves, and then we'll get our conversation started.
Sure. My name's Kelly Close. I'm chair of the diaTribe Foundation, which seeks to improve the lives of people with diabetes and prediabetes and to advocate for action.
I'm Bill Dietz. I'm the chair of the Redstone Global Center for Prevention and Wellness at the Milken Institute School of Public Health.
I'm Frank Hu. I'm professor and chair of Department of Nutrition at Harvard T.H. Chan School of Public Health.
I'm Ann Shookett. I'm the Principal Deputy Director for the Centers for Disease Control and Prevention, or CDC. You know us as fighting epidemics, but we also tackle leading causes of illness, injury, disability, and death. And today we're talking about an epidemic that is of chronic diseases.
And my name is Hugh Waters. I'm the Director of Health Economics Research at the Milken Institute.
Great. Well, Dr. Hu, I'd like to start with you. Can you tell us a little bit, what does the data show about the obesity epidemic?
Well, so let's start with the new CDC data first, because just a couple weeks ago, the data from CDC showed very troubling obesity epidemic in the US population. Currently, almost 40% of the US adults are obese, and almost 20% of children are obese. And I think this data are very troublesome, and also to some degree disappointing, because we have put so much effort and resources into obesity control or prevention in the past 2 or 3 decades, but the obesity trend hasn't really slowed down. And in the past 20 years, there is about 1% unit increase in prevalence of obesity in the US adults. So this means that some of our current strategies are not working, and we have to rethink how we can develop more effective strategies to control the obesity problem. So currently, we are primarily focusing on weight loss among people who are already obese. Several new obesity drugs have been approved by the FDA in the past several years, and more people are undergoing obesity or weight loss surgeries. Nevertheless, the obesity trend has continued to go up. So in terms of obesity prevention, I think it maybe also need to rethink our current paradigm. When we talk about obesity prevention, it may be too late, because most people gain weight during young adulthood and middle adulthood before they become obese. So one of the issues we have recently looked at is whether weight gain during young adulthood and middle adulthood before they become obese, whether that has any health risks later in life. So we recently published a paper in JAMA specifically looking at this issue. Can I have the first slide? So this study was actually inspired by Bill Dietz, 2 years ago, I invited him to give a guest lecture in my class, and he said, the weight gain during young adulthood has become a public health problem, but we don't have much data on this issue. Since you have very large longitudinal cohorts, why don't you look at the health risks associated with weight gain during young adulthood and the middle adulthood? And that's what we did in this study. Using these 2 large cohort studies, and this is a health study cohort, the health professional cohort study with more than 200,000 people, we have tracked their weight, body weight, their diet, lifestyle, health conditions, medical conditions, and so on and so forth in the last 3 to 4 decades. So we were able to look at the long-term health risks associated with weight gain during young adulthood and middle adulthood. Next slide. So on average, people gain a lot of weight, and actually the majority of the people in our cohorts gain weight during young and middle adulthood. The average weight gain in women is about 27, 28 pounds during this period. For men, it's a bit less, it's about 25 pounds. But almost 20% of people gained excessive amount of weight, 20 kilos or almost 45 pounds during young adulthood and middle adulthood. So this is actually a very common phenomenon in the US population. Next slide. So what we found is that even moderate amount of weight gain was associated with various health risks later in life after age 55. So in this study, we found each 5 kilogram weight gain or 11 pounds weight gain was associated with 30% increased risk of diabetes, 14% increased risk of hypertension, 8% increased risk of cardiovascular disease, 6% increased risk of obesity-related cancer, 5% increased risk of premature death, and a 17% lower likelihood of achieving healthy aging in later life. So we define healthy aging as not just living, to 70 years old or absence of chronic diseases, but also having good cognitive function and a good physical function. So this means that even moderate amount of weight gain during young adulthood and middle adulthood is associated with not just chronic disease risk, but also decreased quality of life. Next slide. So one question that was raised is there is a safe threshold for weight gain? What we found is actually a dose-response relationship between the amount of weight gain and the increased risk of chronic diseases in later life. Of course, those who gain excessive amount of weight, like 20 kilograms or 30 kilograms during young adulthood, middle adulthood, had threefold increased risk of developing those chronic diseases. But even for people who gain 10 kilograms during this time period, they had substantially increased risk of chronic diseases. The take-home message from this study is that weight gain during young adulthood, middle adulthood, even before people become obese, is not benign. That kind of weight gain is actually associated with substantially increased risk of chronic diseases, premature death, and also decreased likelihood of healthy aging.
Well, that's really bracing. And Dr. Schuchat, I was hoping you could tell us a little bit about, in terms of prevention and this trend toward weight gain, how our weight gain is maybe undermining some of the gains we otherwise might be making in terms of our health.
Yeah, first I just want to say that as you look at the statistics and as you look at the evidence base that's expanding every day, you just want to go out and stress eat. Yes. So it's just, it's really difficult. Thank you. But, at the CDC, we've been looking at larger trends and recently reported on a couple things that really surprised me. I'm new to realizing that obesity is actually associated with a number of types of cancer. There are 13 different types of cancer that have been linked with obesity and overweight. And the obesity epidemic in America is bad enough now that it's showing up in our cancer statistics. If you put on slide 13, you can see this. For cancers that aren't associated with obesity, we've got a lot of progress. We've had a 13% decline in the cancers that are not related at all to overweight or obesity. Colon cancer is associated with obesity, but we have a great prevention tool. We can do colorectal cancer screening, we can take polyps out if they're there, and we can prevent cancers. We've seen a 23% improvement in the incidence of colorectal cancers. But for the other cancers that are associated with overweight and obesity, that don't have that cancer screening tool, we have a 7% increase at the population level. And the biggest increase is in middle-aged, not the elderly. In young and middle-aged adults is where we're seeing this increase. It's really that wave of overweight and obese adults that are now showing up in our cancer statistics. I know in this room there's a lot of people pretty excited about the moonshot for cancer, but if we don't make a difference in obesity, we're going to really have trouble making a major impact on cancer in the decades to come. So I think what you've been hearing is that the numbers don't look good in terms of prevalence. The chronic diseases that are complications of obesity, like cancer, are getting worse instead of better. And we really need to move back into prevention. It turns out that preventing overweight and obesity is a lot easier to do than to treat it once you are obese. And that's why a lot of the interventions are focused on the youngest age groups, young children. Breastfeeding as a very effective tool to prevent children from overweight or in the early years, and then early childhood and school-based interventions. So I think we have a lot of work to do, and it is easy to go out and want to down the ice cream. But I think as a nation we have to take this really seriously.
Can you talk a little bit about which of those cancers are weight-related? You don't have to name all 13, but things that I won't quiz you.
Yeah, so some that are quite common, like breast cancer, endometrial cancer. I'm going to need to go to my helpline over here for some of the others. Some rare ones like thyroid cancer, relatively rare. But actually the exciting thing is that there's a good biologic basis for why would obesity or why would overweight even be linked with cancer formation. But the good news is that even modest weight loss is now starting to show to be effective at reducing your risk, particularly for endometrial cancer. And then there's exciting evidence for breast cancer survivors about weight loss and weight maintenance as a way to reduce the risk of recurrence.
That's great news. I mean, one of the biggest successes in cancer prevention and overall health has been the decline in smoking. And I know that the decline in smoking has really helped to lower lung cancer rates and heart disease rates and stroke rates. But tell me, how is our weight gain as a country maybe eroding some of those gains?
Right, yeah, we think that there were about 600,000 obesity-related cancers in the United States last year. We have seen huge progress in the tobacco-related cancers, particularly in lung cancer, but this volume of obesity-related cancers is going up instead of down, and they're happening at earlier ages. We actually had a similar issue with our stroke statistics. Since 1999, stroke deaths have really been going down in this country. Better treatment of strokes, early recognition and prompt treatment, and better control of blood pressure to some extent. But most recently, we've seen that decades of decline start to plateau and actually increase. And again, in these middle ages, where these other chronic diseases, not just obesity, but some of the consequences like hypertension, diabetes, that can increase risk of other outcomes. So we really have a challenge as a nation.
Well, let's talk about diabetes. Kelly, can you talk about some of the trends in what you're seeing?
Yeah, absolutely. So of course the trends in diabetes just absolutely mirror the trends in obesity. If you could put up slides, I think it's slide 17, we can see some of that. It won't be a surprise, of course, to anyone in the room. And we know that this exponential increase has happened absolutely everywhere in the world. I think it's just the slide right before that. Thank you. So This is in every region of the world, and you can certainly see in some it's worse than others. We know that in many parts of the world, also, people are at risk for diabetes at an even lower BMI. So that's even why it's even more important for us to try to focus on prevention. And I'm so happy to see such a big prevention focus here, because there are many, many interventions that we are more excited about. It's also really important to know that so many gains have happened in therapy for obesity, and also therapies for diabetes. For example, there are therapies now in diabetes that dramatically reduce cardiovascular risk, that reduce risk of kidney disease, that reduce risk of severe hypoglycemia. And I know we are going to talk about some of the costs. That's just the next slide. We are able to impact some of these costs and really start to bend the cost curve. This is, we know that the costs of diabetes are of about 1.3 trillion a year globally. That means that it is, if you take that down, it's 150 million per hour. Just as long as I've been talking, it's been a few $million. So I'll hand it over back to you.
Wow. Well, the financial cost is really striking. I think here, we're here in Washington, and that really gives policymakers, not just the doctors in the room, some incentive to tackle the obesity epidemic. Dr. Waters, can you talk a little bit about the financial impacts?
Oh, with pleasure. Thank you. So it's rather overwhelming if you look at the big picture of chronic diseases and the threat that they pose for our economy. I'm just going to present some numbers from a study that we've done at the Milken Institute, looking at the prevalence of the variety of chronic diseases that are affecting the American population and the costs of those diseases. So I'll just present some summary results of that. If I could go to slide number 7, please. So this is again, a summary grouping the different conditions together into these categories. These are what we economists call direct healthcare costs, and the translation of that is these are direct medical treatment. People getting treatment from their doctor, going to the hospital, direct expenditures on healthcare, either by families, by insurance companies, by the government. So this shows you that we're spending as a country about $1 trillion a year on chronic diseases, and that's about 5.4% of our GDP. So that's one way to present the puzzle, the pieces of the puzzle. But if we go to the next slide, you can see sort of the full picture of the costs of chronic diseases in the U.S. So these are both the direct health care costs, the doctor's visits, the procedures, et cetera, plus the indirect costs, which are productivity losses. So people that have these chronic diseases, how many days they miss from work, how much their work productivity is affected. And so that we refer to those as economic losses or indirect costs. And if you put those in there, it comes to a whopping $3.4 trillion. Check all the zeros. It's about 18% of our gross domestic product. So that's probably the single most impressive way to present it, or the single most alarming way to present it, if you will, is that the chronic diseases by themselves, these categories of diseases, are costing us almost 18% of our total economy. You can see the groupings. Diabetes, of course, is a major contributor in terms of direct costs and also productivity costs. Cardiovascular conditions include congestive heart failure, coronary heart disease. Those are two different kinds of heart disease. And hypertension, which is a major factor in chronic diseases. Another main factor, risk factor, is high cholesterol levels, of course. That's a big part of this picture as well. So all of these different symptoms and diseases kind of come together. Many of them are related and have the same risk factors that can lead to a variety of these chronic diseases. So the challenge is to find ways to address those risk factors that lead to this variety of chronic diseases. So I would like to skip the next slide and go to slide number 10, if that's possible. So the single biggest factor is obesity. All right, so we'll just take a second to talk about that. obesity of the total cost of chronic diseases is responsible for 41%. So of the slide of the $3.4 trillion, obesity and overweight by themselves are responsible for 41% of that burden, of that cost. So that's sort of a shocking statistic in a sense. I mean, but it gives you a sense of how the obesity epidemic is affecting our health system. Hello?
Yeah, I think just keep talking.
Just keep talking. Okay, there we go. So that's by far and away, obesity and being overweight are to combine the single biggest risk factor. Of course, those risk factors themselves are related to other risk factors. Not getting enough exercise, diet are the obvious implications.
Okay.
Oh, that's a great idea. Thank you.
Yeah.
Okay. So they call health economics the dismal science, and it's for a good reason, right? So let me go to slide, there we go. Smoking and exposure to secondhand smoke, 326 billion, so that's not anywhere near the level of obesity, but still a very important risk factor, exposure to secondhand smoke and primary smoking. And then drinking is also a major contributor to these chronic diseases. So these are things, all of them, that we can do things about. I mean, these are all preventable diseases. So go to slide 11, please. Okay, so the future, if we don't do something about it, is grim. So by 2030, with current trends, 83.4 million people will have 3 or more chronic diseases on the list of the different cancers and other diseases that are included in chronic illnesses. So 3 or more. So you can imagine when you get to people that have multiple chronic conditions, the conditions tend to exacerbate and affect one another in a way that the expenditures increase and people's health status declines more rapidly. So I'll leave it at that. I hope I've depressed everybody in the room sufficiently.
More reason for stress eating. We're going to send you back out to the cookie table on the snacks. Well, I'm hoping, Dr. Dietz, I'm going to give you a big job here because you're going to give us some hopeful messages, I think. So the burden will rest on you. You wrote an editorial in JAMA a few weeks ago looking at the need to target one particular group and why that might be important and why we might make headway there. Can you explain that a little bit?
Sure. Well, I wanted to share with you the data that prompted Frank's article to begin with, because that begins to make the case for a focus on obesity in young adults. If I could have slide 5, please. This slide will show the prevalence of obesity at different ages. So you can see that about 9% of 2 to 5-year-olds, and I should emphasize these are 2011 to 2014 data, and Haynes measured heights and weights. So 9% or so of 2 to 5-year-olds have obesity. That about doubles in 6 to 11-year-olds, where 17% have obesity. But then it doubles again in the 20 to 39-year-old age group. I should also comment that, as Ann pointed out, the new statistics differ a little from this. And one of the concerns is that this 9.5% in 2011-2014 jumped to 13.5%. And the 17% in 6 to 11 years old jumped to 18.5%. Now, I don't know what that means, but it's not the best of signs, and it should raise concerns. Nonetheless, I think this is what got me to begin to focus on this 20 to 39-year-old age group. As the next slide shows, and this includes some of the 2 original studies which I was concerned about. These are studies that are 10-year follow-ups, one of N. Haynes from 75 to 85, a 10-year follow-up. Notice that the prevalence of excessive weight gain, defined here as 5 BMI units, which is roughly equivalent to 20 kilos depending on size, was 4% of women, 4% of men, 8% of women, higher among African American men and women. And the Cardia study done 10 years later showed another increase. So again, African American women were higher than white women, 22% versus 9%. And so this really began to indicate a secular trend. Now, these were samples that were mixed in terms of ethnicity, African Americans and whites. In contrast to the health professional follow-up study, which included white men, and the nurses' health study, predominantly white women. And notice that, and this is the study that Frank published, that 13% of men, but 22% of women gained 20 kilos over this period of follow-up.
And 20 kilos, for those of us who are
44 pounds.
44 pounds. Okay,
Right.
wow.
Now, the other thing that is relevant here is this period also seems to be a period of onset of obesity, not just excessive weight gain. And it begs the question, what's going on? Well, we don't know, interestingly enough. Beyond the ethnic demographics here, we don't know what the life cycle transitions are, which are associated with this increase in obesity. But one leading candidate, in my view, that may explain the disparity between weight gain in nurses and weight gain in men is postpartum weight retention, an understudied condition, but that may account for some of the differences in prevalence of excessive weight gain during this period. And that begs another question. So if these women are gaining weight during pregnancy and retaining weight after pregnancy, what happens to their children? We don't know, but it makes sense that there would be synchronous changes in weight, that the mother's weight might also affect the child's weight. And that's led to another study that we hope to get funded, looking at the synchrony of weight changes in a number of data sets which pair mothers and children. The other set of studies is, who are these people and when is it that they're gaining weight? If you think about young adulthood, there are more life transitions in young adulthood than almost any other time in life. People become autonomous, they go to college, they begin to consume alcohol, they start a family, they have a job, they have children. All of these transitions could potentially explain why this occurs. So that's on the research side, but on the practical side, the question is, what do we do? One of the questions that was, you can go back to the main slides if you like, because I have no further slides to illustrate here. But this morning a question was asked, why isn't there more being done about the obesity epidemic? And one of the major problems that I think blocks progress and blocks investment in this issue is the stigma and bias associated with obesity. And it begins with language. We tend to talk about obese people, not people with obesity. And there's a very important distinction, because an obese person is an identity. That person is not a teacher, that person's not a parent, that person is obese, as opposed to a person with obesity, which is a person with a disease, and it separates the disease from the person. This is commonplace language in other fields. We don't talk about cancer people, we talk about people with cancer. And we need to apply those same standards, because I think when we talk about obese people, we tend to blame them for that problem, and therefore don't invest in helping to cure this problem. So that, I think that changing the language, changing the conversation about obesity, and addressing the bias and stigmatization that occurs is important. The only condition that is more stigmatized in our culture is being black, that obesity almost approaches that level of discrimination. But these young adults, I think, are an important target, because effective prevention of obesity in young adults may help prevent obesity in their children. So think about what young adults, what organizations, what kinds of settings or environments these young adults are functioning in. Well, colleges or universities are one of these areas. And there is a Healthy Campus initiative that was initiated by the Partnership for a Healthier America, which begins to focus on those issues, better nutrition, physical activity in college students. Employers who hire people for long periods of time should be concerned about this and should be monitoring this. And the example from earlier today about the investment in prevention of chronic diseases in employees, particularly long-term employees, pays off and caps healthcare costs. And that isn't to dismiss the importance of a staged approach to prevention that begins with baby-friendly hospitals where nursing babies is the norm, not the exception. Follows with early care and education strategies to improve nutrition, physical activity. We know about schools, and in the physical activity session, there was discussion about the elimination of PE, and one state, I can't remember which it is, had just decided to, was it Florida, I think, to add recess, and the state legislature, now that they've added recess, wants to take away physical education. Well, that makes no sense at all. And then community strategies, that access to healthier food, that physical activity facilities that are readily available. Those are strategies that we need to begin to employ if we're going to begin to turn the corner on this epidemic.
Well, thank you. That was a great presentation. Not quite as peppy and optimistic as I was hoping, hoping it would be. And you know, really, what I think all of these numbers show is something that I've been thinking about. I was at USA Today for 13 years before I came to Kaiser Health, and we covered obesity and the struggles against the battle of the bulge there. And if you look at the numbers, I really sort of wonder, is our default mode to become overweight and obese? So there are times when I walk into my neighborhood supermarket and I look around and I think 80% of the food in here will kill me. And I don't want to get letters from the grocery manufacturers of America, but I've really started to think, you know, is that if someone doesn't take a really serious make a really serious effort to go against the tide, you know, is the default mode for all of us to just become overweight? What do you think? Is that a crazy idea?
Yeah, I think our society where we live, work, play, go to school, we're just immersed in things that could be difficult. And so, you know, a strategy in general in prevention is to make it easy to do things that will help you. You know, the healthy choice, if it's the easier choice, it's easier to make. It's less of a willpower kind of thing. But I do think that the size of our problem right now, the number of people who are struggling with overweight or obesity is very, very common. You know, it's the majority of Americans right now. And it can be overwhelming to think about how you're going to deal with it, whether you're at the grocery store or the restaurant. But small changes can have impact, and I think that's a key message to take home. We've found that modest weight loss, you know, like a 5 kilogram or 12 pound weight loss can be enough to reduce your risk of developing diabetes. Modest physical activity can reduce your risk of going on to diabetes. You know, 30 minutes, 5 times a week. And everybody can make those little changes. Everybody feels like I don't have time to eat right and I don't have time to exercise. But you really don't have time not to, in terms of what the impact it has on your health, on your business's health, on the community.
So I think the new statistics, I think should make us kind of rethink our strategies and reflect on what has been working, what hasn't been working. I mean, we spent years talking about multi-pronged approaches, systems approaches, changing the food environment. The soda consumption has actually decreased, and there are more healthy food stores or restaurants, and the new functional foods almost every day. And a lot of people are undergoing obesity surgeries. So all those positive development have not led to the decrease in the population obesity statistics. So I think that's very troublesome. We should look at other countries, economically developed countries which do not have this kind of obesity problems. Only a few economically developed countries have very low prevalence obesity. So look at Scandinavian countries, Denmark, Sweden have very low prevalence of obesity. Japan has very low prevalence of obesity. So what kind of common characteristics those countries share? I mean, if you have traveled to those countries, you would notice that their food environment is very different. Their physical environment is very different, and social norms is very different, and people value more food quality than quantity. And in some cultures, self-control or self-restraint is considered as a virtue. But here, of course, we always want more and more. And if you look at the food environment in Denmark or in Japan, I mean, portion size, of course, is much smaller, but the type of foods in the supermarkets are very different from what we have. I mean, we have mostly highly processed, refined, high sugary products. And the government, of course, has much stronger, stricter policies, regulations on foods, the type of foods, and also on taxation, marketing, and as you know, I mean, the marketing strategies by the big food companies, beverage companies, are very aggressive, very misleading, especially to our children. So I think, again, we have been doing a lot of things in this country in the past several decades, but we really need to look at what's happening in other parts of the world to see whether we can learn something from those populations which have not experienced this kind of problem.
Could I just, I would love to add to that. I think it's so smart about looking at what's working, what's not working, and what's scalable. And I completely agree with you, Dr. Hu. I was lucky enough to be able to go to a gathering a couple of years ago called Cities Changing Diabetes. That was in Denmark. And we got to see so many different interventions in Copenhagen. And it is, you know, the way that people ride bikes there. You know, if you go to some of the major companies, you know, a piece of pizza for lunch is $10. A salad is $1. You know, we all know, of course, that nudges have to go in the right direction, but it's really happening there. I think what we did based on that is we went back and said we'd love to talk to prevention experts and people very focused on prevention around the world and understand what's happening and what's positive and what actually is changeable. And if you're interested in this research, you can go to diatribe.org/anthology. And you can see some of the insights from talking to over, over 100 people. We brought out 25 examples of prevention and what are the good things that are happening. I think that will drive investment. And today, it's not the global financial recession. I also think considering how philanthropy could be brought into this and more public-private partnerships would be really valuable.
So I'm optimistic, actually. I think some of the changes we're seeing, like the preference for communities which enhance physical activity, the design of communities, which is a fundamental characteristic to encourage walking, biking, or public transport. We know that people who take public transport tend to be more physically active. Those types of communities are desirable. And it would be interesting to cross the walkability and bikeability of those cities with the healthiest cities for aging that we saw earlier. That would be an interesting study. The other convergence, I think, is coming out of the food industry, where we've seen recently that the most profitable products are the healthier products. That's where the growth is, and we had a whole panel on that earlier. The one thing that we haven't talked about, which I think is a huge barrier that we need to address, is the disparities that exist with respect to the prevalence of obesity. It's much higher in African American women. Another finding in the most recent CDC statistics were that the prevalence in Hispanic women, which used to be lower, is now not significantly different from the prevalence in African American women. The prevalence in African American women is 54%. In Hispanic women, it's 50%. That the lack of a statistical difference there may be that the samples are pretty small. But unless we address those disparities, we're not going to solve this epidemic. And the solution to those disparities has to be more investment in those communities. For example, the East End of DC, which is across the Anacostia River, predominantly African American community, has 3 grocery stores for 150,000 people. The comparable rate for other wards in the city is like 20 per 150,000. So access is one thing. The same thing is true of access to facilities or opportunities for physical activity. And I think combining changes in infrastructure and changes in access begins to address the disparities and make these communities much more livable.
I love your mentioning of livable communities, and I'm very interested in what people call the social determinants of disease. You know, what's your environment? Where do you live? What's your income? You know, what's going on with your parents in your house, and how those affect our disease rates. I mean, I'm really interested and terrified by the idea that the obesity trend is getting so much worse, and I wonder. This is just a wacky idea, so feel free to knock it down. But I wonder, does the obesity epidemic get so bad that it becomes self-sustaining or self-perpetuating? Not to be wacky about it, but I had spent some time on a message board for people who've had knee surgery, and and people get heavy, they get arthritis in their knees, and it becomes harder to exercise. And they'll go to their doctor with knee pain, and they say, well, you need to lose some weight. And so the heavier they get, the harder it is to exercise. I've done a lot of writing on the microbiome, all the germs that are in and on our bodies, and there's interest in, does the processed food change our microbiome to make it easier to gain weight? I just sort of wonder, why it is that this obesity trend is accelerating and getting worse. Is there some explanation?
Well, I can address the maybe. I can address perhaps the social and economic aspects, not so much maybe the biological ones. Certainly there's been a change in our culture and the way we view people that are obese and people that are overweight and obese both. But part of that has been a change in our lifestyle. I mean, we have to really look much closer at the way we've changed, the way we organize our cities, the way we get to work. We spend lots of time behind the car. And there's so many different factors that contribute to obesity and to other chronic diseases that are related to lifestyle. And diet is the most obvious one, but just the way we're physically organizing our society does not lend itself to people getting exercise and living healthy lives. So that's obviously a very long-term kind of agenda. But I would like just to point out one other hopeful note. I mean, we have natural allies in this in terms of employers and insurance companies. Both are have a very, very strong investment in preventing chronic diseases and managing them once people get them. So we need to really work closely with both of those two sectors. And obviously sometimes some employers are self-insured, so sometimes they're the same entity. But if you look at, Blue Cross Blue Shield has put into place some very innovative ways of managing chronic diseases and keeping the cost down and keeping the prevalence of complications down. And patient-centered medical homes, accountable care organizations, and employers. Some employers have put into place some very innovative employee health programs, given incentives to their employees to actually do exercise and eat well. And there's some really interesting experiences out there that I think that could be shared. So there are allies in this battle, and so I think we need to take a very big picture look at it.
See, one factor we haven't talked about is sleep deprivation. I think this has become a major problem in the U.S. population. In the past 2 or 3 decades, the number of hours people spend on sleeping has actually decreased over time. Now there is very strong biological, epidemiological data showing that inadequate sleep or sleep deprivation is associated with increased production of hunger hormones and increased intake of calories and increased weight gain and obesity. So it's not just sleepless in Seattle, it's sleepless in America everywhere. So this has become even a bigger problem in children because they have their cell phones in their bedroom, have TV in their bedrooms, and this problem is actually directly related to unhealthy eating patterns and lack of physical activity.
Well, I think the community issue is something that people in the Washington area can identify with, because I think data show we've got one of the worst commutes in the country. You think about how much time all of us spend commuting. When I think about maybe one reason, non-biological reason, women might struggle with weight. If you're a parent, a working parent, especially a single parent, trying to put a healthy meal on the table while you're working and commuting, these are real challenges. So I think a lot of people fight those battles alone. I don't know. Are there communities that are trying to help strengthen families so that it's easier to put healthy food on the table?
Yes, absolutely. Esther Dyson is in the room, and Weta Wellville is a great example of one. I also think absolutely the Robert Wood Johnson Foundation has been doing so much on the wellness front and a culture of health. I would love to see even more investment and even more partnership in efforts like this. I also just wanted to say I think it's really great what the Milken Institute is teaching all of us. If we've watched the slides go back and forth, I mean, we know this point about screen time, and we all saw the slides about screens last night, and lower income kids are spending so much more time on screens. I'm a parent of 3 kids, I'm ready to know, like, what's the research we need to do here? What research are we waiting for? Because it's been a while now since the iPhone and the iPad were invented. Of course, there are great things about productivity from those ends, but specifically how children are interacting with them is something that I think we could do a lot more to invest in, especially on the research front. And I would be really curious to know what the rest of the panelists would most love to see on the research front.
Well, I'd like to see the promotion of efficient parenting around screen time. Yeah. I think the parents don't know how to control it. Right? They pick their battles, and one of the battles is not screen time. Yes, it is also really interesting. I think what parents hear is, okay, not more than 2 hours a day from American Pediatrics, and then it's like, oh, wait, okay, we're gonna go study this a little more. I mean, the messaging isn't also completely clear, and also what the schools are doing themselves. We would love to see more investment in what's working well and how to propel that. Well, just to modify my response, I think we know what to do. I don't think we know how to do it. And we've been focused a lot on what. I mean, this panel started focusing on the what and the significant diseases, but the how to do it is what we need to learn and apply. And I don't, as a reporter who covers some politics, and I think maybe our struggles also come from the fact that we as a country aren't really united on what to do about obesity. I think a lot of researchers will view obesity as a community problem. It's hard to believe in the past 30 years that all of Americans suddenly became gluttonous and more lazier. You sort of have to, it sort of lends itself to the idea that there's a community societal effect. There are a lot of people who don't want the first lady to tell their kid what to eat at school lunch, right? I think some of us were surprised at the idea of the first lady telling people to eat their vegetables and go play outside was as controversial as it was. So I wonder if that's part of our problem, is that we don't all, maybe everyone in this room, but outside the room, it seems like there's still, as a country, maybe a lot of disagreement. Is this a societal problem or an individual person's problem?
Yeah, I was just going to say, I think as a country, we like things to be simple. We like quick fixes. I'm a vaccine person. If we had a vaccine to take care of this, it would be fantastic. But it's actually pretty complicated. And I think we know some things that work in very intense intervention contexts, but we don't know how to scale them. And we're really stuck in this, throw everything we have at an issue like obesity or a complex chronic disease like this without finding ways that we can really diffuse them across the country and reach every community, rural, urban, low income as well as wealthier folks. And the time between the research project and the ability to scale is just terrible. I mean, it's amazing to me. I'm looking at your nurses' health study and thinking, thank goodness you weren't following my weight gain since 1976. But I also think it takes a huge amount of investment to do this great quality research. We have to find ways to do this scaling research more quickly so that we can get solutions that work.
Well, I have and praise for the CDC on that front, and also a question. You know, I think the Ad Council and the CDC and the AMA and the ADA did a pretty amazing campaign last year on pre-diabetes. And I know that you got to 1 million people, went to the website and took the risk stratification test. And I mean, in our world, 1 million people doing anything is pretty great.
It was cute animals, that's why it worked?
Yeah, and it was even the one before that, the sort of the busy mom and the I love bacon. But I mean, so it's great to get to 1 million, but what kind of investment do you need to get to 80 million people taking this, or even 10 million, 5 million people? What would you like to see the CDC do? What would you like to see employers do?
I don't think Ann can answer that question.
Well, no, what I would just say is
asking
our most successful campaign was the TIPS campaign, which really helps link people who want to quit smoking with smoke cessation. And you know, it's incredibly cost effective. It has proven results. It's helped, you know, 500,000 people quit smoking since we've been doing it, and that is just saving a lot of lives. But we know that you know, the media environment's very expensive, and the resources needed to really bring some of these efforts to scale are huge. You know, we're launching a campaign around the opioid epidemic, and we're just able to do it in 4 states because of the cost of this type of intervention.
And it seems like on risk stratification, you're being very smart, so we'd love to see more of that in obesity and diabetes.
Unfortunately, we're over our time.
Well, let me say one thing that Ann can't say, and that is CDC is the nation's prevention agency. And unless we continue to invest or increase the investment in the CDC, our prevention efforts will fail.
Thank you.